Next up, I'd like to welcome the extraordinary Dr. Eitan Dickman. Dr. Eitan Dickman trained in New York City. He is an NYU graduate, continued through his training at Jacobi, where he graduated from the EM residency program, and self-describes as an ultrasound zealot. He was one of the first ultrasound fellows at Christiana Healthcare. And it turns out that he has sort of shifted into more of an operational and leadership role. He currently is the executive vice chairman at Maimonides Medical Center in Brooklyn, New York. I refer to him very affectionately as my boss. And today he's going to get back to his ultrasound roots and talk to us about the ultrasound approach to the dyspneic patient. Thanks so much, Dr. Dickman.
Good morning. Thanks for the introduction, Sally. We're going to be speaking today about the sonographic approach to the acutely dyspneic patient. And there's a lot of material here to cover, so let's dive right in. As a bit of background, I suppose the question is why speak about this topic? We all know we work in the emergency department. We know that shortness of breath is a very common chief complaint. It turns out that almost 8% of all ED visits are related to shortness of breath. This translates into millions and millions of visits across the country. And as our population in this country ages, and we look at the most common reasons for admission for the 65 to 84-year-old age group, we can see that in those who are coming in due to CHF, pneumonia, and COPD, shortness of breath is going to be a very common reason for their admission. But in addition, those patients who are admitted due to sepsis and dysrhythmia oftentimes will also have shortness of breath as a key component. And so we see that shortness of breath ends up leading people to come to the ED, and it's also a common reason for patients to require admission to the hospital. Now, over the last 10 to 20 years, there's been a significant change in hospital culture. In the past, the emergency physician was charged with resuscitating patients, stabilizing the patient, and ensuring a safe disposition. Admit versus discharge, admit to the floor versus admit to the ICU. However, I'd say within the past 10 years or so, there's been a real culture change, and it is now the emergency physician is expected to be the primary diagnostician for the hospital. And there's a real implication. We want to make sure that we're accurately diagnosing our patients. And the days of admitting undifferentiated abdominal pain or undifferentiated shortness of breath to the hospital is really falling by the wayside. And so the diagnosis attributed by the emergency physician has significant implications for patients being admitted. This was demonstrated very nicely in a study that was published a few years ago, in which they looked at over 500 elderly patients who came in due to shortness of breath and were found to be in acute respiratory failure. Now, in 80% of cases, there was concordance between the ED diagnosis and the ultimate hospital discharge diagnosis. The corollary of that, of course, is that in 20% of the cases, there was a discrepancy and the ED diagnosis was felt to be inaccurate. And when you looked at the two groups, there was a significant difference in hospital length of stay, but more importantly, there was a significant difference in mortality rates. So the diagnosis we come up with in the ED really has significant implications. Now, 20, 30 years ago, when point-of-care ultrasound was first introduced to the ED, everyone was very excited about the FAST exam and the ability to detect internal hemorrhage. I would actually argue that as the population ages and as we're seeing more and more patients present with shortness of breath, thoracic sonography is actually the most important diagnostic application that we utilize on a regular basis in the ED. Let me illustrate that with a case. So this was a 78-year-old male, history of diabetes, hypertension, CHF, and COPD, who presented with acute shortness of breath. He was somewhat tachycardic, tachypnic, as well as hypoxic. And due to body habitus, lung exam was somewhat limited. So in the past, maybe a shotgun approach would have been employed, treating the patient for both CHF and COPD. Maybe they would have been waiting for a chest x-ray, BNP, other test results. However, nowadays, shortly after arrival, the probe is placed on the patient, and very rapidly we can see B-lines, diffuse B-lines. And if this image was also obtained from the other side of the chest, we know that we're dealing with acute pulmonary edema, and we can initiate treatment in a rapid manner. Because this looks significantly different than A-lines, here we see the pleural line between the rib and shadow, and we have these recurring reverberation artifacts, which are known as A-lines. And Daniel Lichtenstein, who's really the father of pulmonary ultrasound, showed years ago in his study that Diffuse bilateral B lines was seen in 100% of patients with acute pulmonary edema, whereas those whose respiratory compromise was due to acute COPD or asthma exacerbations had bilateral A lines. And one of the conclusions of his study was that respiratory distress without evidence of B lines effectively rules out pulmonary edema as the etiology of the patient's respiratory distress. So one of the takeaways is you need to be able to rapidly and accurately differentiate A lines from B lines. Next case, 87-year-old female with a history of diabetes, CHF, and hypertension who presents with shortness of breath after recent hip surgery. She was tachycardic, somewhat tachypnic, and hypoxic. Now, in this case, the diagnosis was fairly straightforward. In this apical four-chamber view, we can actually see thrombus on the right side of the heart. This is a clot in transit, and so we know that pulmonary embolism was the cause of her hypoxia. And the question often comes up is, how good is point-of-care ultrasound for the diagnosis of pulmonary embolism? And the answer is, it depends. For small subsegmental PEs, it's actually not a great test. However, as the PE becomes larger, there's increasing clot burden, and there's strain on the right ventricle, there's some signs that we can look for with ultrasound that are actually quite helpful. We can look for dilated RV, we can look for D sign, we can use McConnell sign, and we can utilize our TAPSE measurements. Let's go over this briefly. Here we see an apical four-chamber view. We can see the right ventricle is significantly dilated. Normally, that should be 2/3 the size of the left ventricle. Here it's dilated. But in addition, we can actually see the RV apex, which is really cranking over there. It's very hypercontractile. And that's an example of McConnell sign, which is highly suggestive of a PE. In the parasternal long axis view, the RV should have approximately the same diameter as the LV, left ventricular outflow tract, as well as the left atrium. It should have a 1:1:1 ratio. If you see significant enlargement of the right ventricle, that's suggestive of increased right heart pressures. And in the left ventricle, in the parasternal short axis view, the left ventricle should really be taking up the majority of the view, with the right ventricle being draped over the LV and having an ovoid appearance. As opposed to this view in which the RV is significantly larger than the LV. And due to the increased pressures in the RV, you can actually see some flattening of that interventricular septum known as the D sign. If you have a high suspicion that your patient has a PE, you can also look at the vasculature of the lower extremity. In this case, we're looking at the femoral vasculature. We can see here the common femoral artery and the common femoral vein. And even with compression, the common femoral vein is not collapsing, indicating that there's a DVT. And in a patient who's hypoxic and short of breath, this is highly suggestive of a PE. Now, TAPSE is probably underutilized in the ED. TAPSE, which stands for tricuspid annular plane systolic excursion, provides a very nice global assessment of RV function. And it's been shown in multiple studies to offer prognostic information, including about the need for ICU level of care, as well as mortality outcomes. The view is obtained from an apical four-chamber view, and you're going to place the M mode spike over the lateral tricuspid annulus. There is some controversy in the field, but usually we can use 16 millimeters as a cutoff. Anything below 16 millimeters is considered abnormal. And you're going to want to take the average over several cycles. So here we have an apical four-chamber view. You can see the M mode spike has been placed over the lateral annulus of the tricuspid valve. And here we're measuring from peak to trough with a measurement of 28 millimeters, which is above that 16 millimeter cutoff. So this would be a normal value. Let's shift gears and speak for a few minutes about the use of ultrasound for a disease which has had an immeasurable impact on all of us for the last year, using ultrasound for COVID. When looking why would we use ultrasound? A year ago, if someone came in with respiratory distress, we knew that it was COVID. But then again, if someone came in with an ankle sprain, we knew that they also had COVID most likely. And so now with increasing number of people who are vaccinated, we have again our wide differential for people who are coming in with respiratory compromise. And the use of ultrasound early on in patient care allows for appropriate triage. It allows us to make sure that we do what we can to separate patients who have COVID from those who don't. And in addition, ultrasound allows us to assess how much of the lung has been affected by the virus. So we know that COVID-19 has a predisposition for infecting the lower respiratory tract. And from an imaging perspective, we're going to look for bilateral consolidations, in a patchy distribution, and the consolidations tend to be out towards the periphery, which from a lung ultrasound perspective is actually helpful because that makes it more amenable to sonographic diagnosis. although the findings can be nonspecific. So what are we going to look for? We're going to see focal B lines with pleural thickening. We're going to see an irregular pleural line, as well as disruption of the pleural line. As the disease worsens, we're going to see diffuse B lines and subpleural consolidations. When the patient starts to improve, we'll see A lines. And it's unusual for patients with acute COVID to have pleural effusions. So if you see someone with a respiratory compromise who's got significant bilateral effusions, you should be thinking about a different etiologic agent. Here's a nice example of B lines and then some focal sparing, and then B lines, and then some focal sparing. This nicely demonstrates the patchy involvement of the lung in the setting of this illness. Here we have rib and shadow and rib and shadow, and just deep to the pleura, we've got these subpleural consolidations, which can occur in the setting of COVID. Now, normally the pleura, as you know, will be a thin, white, hyperechoic line. Here we have some irregularity of that pleura, which can be seen in COVID. And here's a more significant example of that, where we see a fair amount of disruption of that pleura, as well as some B lines. Here's another example of some discontinuity of that pleura, as well as a subpleural consolidation, which occurs with COVID. And this was a patient that I saw recently during a shift on the critical side of the ED. This was a 65-year-old male who complained of acute onset shortness of breath. He was somewhat tachycardic, but impressively hypoxic. And due to the times that we live in, he was triaged to the COVID section of the ED. And surprisingly, about 25 minutes later, his point of care COVID test came back negative. So based on that, he was moved out of that section and into the main part of the ED. And the ultrasound team happened to be coming by. And so they scanned the patient. And what they saw was the patient had diffuse B lines on the left side of his chest. And as on the right side, he also had diffuse B lines. Remember, this person had no history of cardiac disease. But also, if you look closely here, you can see that there's some irregularity and some thickening of the pleura. So based on this constellation of findings, there was concern that the patient may have COVID. You can ignore these other measurements, but here there was a measurement of TAPSE, and you can see that at 32 millimeters, he was well above the 16 millimeter cutoff. So based on these findings, he was moved back into the COVID section of the ED. And sure enough, about 2 hours later, his PCR came back positive for COVID. He was treated with steroids and admitted to the hospital, again, demonstrating the utility of early use of ultrasound. So looking ahead, where does this technology taking us? So we know that there's miniaturization of the ultrasound probes, as well as consistent improvement in image quality. We now have probes that can plug into our phone. There's some that can even connect to our phones wirelessly. And this is occurring simultaneously with big advancement in the field of AI as it relates to ultrasound, particularly through the use of deep learning, which uses large amounts of data to essentially teach machines how to interpret images through the use of neural networks. This was demonstrated nicely by Rob Arntfeld, who recently published a study in which they took over 600 videos, lung ultrasound videos. All of the clips had B lines, but the B lines were of differing etiologies. Some of the B lines were due to cardiogenic pulmonary edema. Some of the patients had ARDS due to COVID, and some of the patients had ARDS due to non-COVID etiology. And interestingly, after teaching the machine how to what the correct diagnosis was, they then showed additional clips, and the computer actually performed better than ultrasound trained clinicians. So the authors postulate that there may be some subvisible characteristics, whether in the B lines themselves or in the pleura, which allowed the computer to perform better than the humans in interpreting the etiology of the B lines. So AI is here. FDA last year approved the first AI for ultrasound. Several machines, including those marketed towards the ED, already have AI software built in as part of their standard operating system. And the primary focus to now has been on the use of lung ultrasound and echo for AI, and with improvements both in image optimization as well as interpretation. So this is just going to make for a very powerful tool. I mean, we use ultrasound in the New York City area routinely when we have access to a tremendous amount of additional resources from an imaging perspective. Imagine if you were working in a rural part of the country where they had less access to CT, or in particular MRI, or outside of this country in low resource settings. This is a very powerful tool. So to bring it home, you really want to become an expert and facile with thoracic sonography by performing the scan early in any patient who comes in with respiratory compromise. And if there's any change in their clinical status, repeat the scan, see if anything's changed. From a COVID perspective, scanning these patients early on allows you to hopefully isolate them from the non-COVID patients in your ED, as well as allowing assessment of how much of the lung has been infected and affected by the viral illness. From a trainee perspective, you want to make sure you can differentiate rapidly and accurately between A lines and B lines, and then move on to pleural, looking for any irregularities, effusions, and consolidations. This is going to make you a better diagnostician and improve your patient outcomes by allowing them to be diagnosed faster and appropriate treatment initiated more rapidly. Thank you for your time.
Wow, Dr. Dickman, thank you so much. I really appreciate you taking the time to drop those knowledge bombs on us. And the one thing, if there's one thing that I've learned from you in particular, it's scan early and scan often, and don't forget to document it.
That's right. Thanks, Sally.